So I will talk today about developing, evaluating, and implementing novel interventions focusing on parent mental health in families of youth with ADHD. And these are my financial disclosures. How it all began, I was lucky to be mentored by Dr. Pelham, particularly since my original graduate school mentor decided to retire after my first year. And it was just serendipity that Dr. Pelham came to the University of Buffalo, and the rest is history. So one of the things that I think has really informed all the work that I've done, and I think it's the case for most people who studied with him, is that there was this true focus on the interplay between clinical observations and research, such that the topics that we explore were really things that were inspired by our contacts with youth and families. And that research that we would do would then in turn inform how we treat children and families. And I think that theme has sort of influenced the rest of my career and the students that I teach as well. So in line with that, my dissertation was based on observations of how many of the parents, and at that time we were just studying mothers of children with ADHD, were often feeling very depressed, depleted, didn't feel like they had the energy, the stamina, the motivation to do all that was expected of them with our behavioral interventions. And so beginning 1 year after the STP, we added on a CBT treatment for the parents. And it's interesting, I think somewhat rare, that to this day, that dissertation that Dr. Pelham encouraged and inspired is still influencing the work that we do in my lab to this day. So this translational research process, whereby we make clinical observations and then study those observations, often through developmental psychopathology, longitudinal research, that then informs treatment targets, treatment development, testing, and then now, like many others, I've been focusing on implementation in real-world settings. So my overarching research program focuses on identifying early risk and protective factors that predict developmental outcomes for youth with ADHD, and particularly focused on modifiable risk factors. So risk factors that we could actually do something about, or protective factors that we can bolster in the child's environment to bring about more positive outcomes. And so by early, I mean beginning in infancy, and I won't talk about too much of that work today, but we have done work looking at early infant temperaments in combination with parenting to predict developmental outcomes. And then the outcomes we focus on might be things like depression, suicide, and substance use. And as I'm saying this, I realize that I've been lucky to have so many former FIU students go through my lab in one way or another, and also to send so many students to FIU. The risk and protective factors we've looked at have included things like parenting, parent mental health, and emotion regulation. And as I said, we develop interventions to improve developmental outcomes for individuals with ADHD. And so I think most people here know the DSM-5 ADHD symptoms. And as we talk a bit more about parents, we'll talk about how this might influence parenting. Many years ago, Charlotte Johnston, who was another Pelham graduate, and I developed this transactional model of ADHD in families. And I think it's widely recognized that the causes of ADHD are largely genetic and neurobiological. Yet the work that we and others have done have shown that these multiple interacting factors truly do influence how children with ADHD do over time, whether they experience those more adaptive outcomes or more serious adverse outcomes. And so these factors are things like parent characteristics, parent-child relationship, co-parenting relationships, sibling relationships, cultural or social factors, and then other factors within the community that might predict whether the child with ADHD has the support and scaffolding that they need to be successful. So these factors do matter. Many people think that, well, if this is largely genetic and neurobiological, then medication is the only answer. But the work that we and others have done have really shown that these factors do indeed make a difference. And what we see is that the parents are really left to be major advocates for their kids, right? Parents are the gatekeepers oftentimes in terms of what kind of care and scaffolding the child gets in different settings. So we really do ask a lot of parents, and at the same time, it's really hard for parents to keep up with all the things that we ask them to do. It's very, very challenging. They do get tired. They do get discouraged. They do get beat down. Our evidence-based interventions for youth with ADHD, and Dr. Pelham inspired a lot of these studies, include things like stimulant medication, behavior therapy at home and school, organizational skills training, combined treatments. And what's really important to know is that all of these treatments really rely on parents, right? As I said, parents are not only the gatekeepers, but they're really asked to be the arm of the therapist. They're asked to change the structure of the household. They're asked to be consistent in terms of contingencies and routines and things like that. And they're asked to provide support around organizational skills. So just imagine if a parent is struggling with depression or anxiety or ADHD themselves, it can be really hard for them to do the kinds of things that we ask them to do. I think something's a little off with the formatting here, so bear with me. But today, what I'll talk a lot about is parent ADHD, because we know that ADHD is one of the most heritable mental health conditions, and 25 to 50% of children with ADHD will have at least one parent with ADHD, and 80% of adults with ADHD who have children will have at least one child with ADHD. So imagine, thinking back on what we ask them to do, how difficult that is when they have ADHD themselves. And so we've done many studies looking at how parenting is impacted when the parent themselves have ADHD. And these are a couple of reviews. We see lower levels of positive parenting, inconsistent discipline, more home chaos, difficulty with supervising such that kids end up in the emergency room more. There's less structure, organization, routines, more chaotic households, and harsh reactions to some of the challenging behaviors that these children show. So really there are two sort of groups of parenting skills that are impacted by ADHD. One is the more executive functioning aspects of parenting, the planning, the organizing, the problem solving when the schedule doesn't go as planned, and then the emotion regulation aspects of parenting. And those are the harsh or negative reactions to often challenging child behavior. Okay. The first study that we did, trying to look at, okay, well, how can we treat parents who have ADHD, and will that result in improvements in parenting and child behavior? And this was done with Children's National Medical Center. And what we found in this study is that although stimulant medication improved parents' own ADHD symptoms, it really didn't help much with their parenting behavior, and simply medicating parents wasn't enough to help children improve their behavior. Which led us to some research questions. First, how do we sequence and personalize treatments for mothers with ADHD and their young at-risk children? Does every family need both parent medication and more of a behavioral approach to help with parenting? What are the moderators? Can we delay the need for stimulant medication for young at-risk children? by treating both parent ADHD as well as parenting. And so we did this pilot SMART. And this study was a small pilot, and here we randomized parents to either get stimulant medication or behavioral parent training first. And for those non-responders, we decided we randomized them to either continue the first-line treatment or to get the other treatment. And what we found, again, is that stimulants improved ADHD symptoms in parents, but really didn't improve parenting skills and child behavior. So we replicated that finding. But that behavioral parent training did improve parent skills and child behavior. And so the combination is likely needed for most families because it results in the greatest improvement in parenting and child impairment. But yet these treatments aren't necessarily widely available, and that's why it's wonderful that you're all here to learn about these treatments. We found that many kids were still struggling, and some needed more intensive behavioral interventions and medication. So this is the publication from that study. So this is the study that we're doing now, which we call TPAC. Treating parents with ADHD and their young children. And so this is what I'll talk about for the majority of today. First, we're trying to improve access to these treatments by moving the research out to pediatric primary care using a hybrid effectiveness implementation design. We're targeting 3 to 7-year-old stimulant-naive children with ADHD symptoms. We're doing routine screening for parent ADHD in pediatric settings. We're using telehealth to deliver parent ADHD medication and behavioral parent training. And community stakeholders are providing input throughout the study. Then the question is really, does parent stimulant medication plus behavioral parent training have better effects than BPT alone on parent, child, and parenting outcomes, as well as engagement in and adherence to BPT? So in other words, in BPT, we ask parents to make a lot of changes to the home environment and how they respond to their child. We wanted to know if when they're medicated, are they better able to do those things that we ask them to do? Do they practice the skills at home more? So why pediatric primary care? Well, we know that pediatricians are often the first the first providers that diagnose and treat ADHD. And parents often feel more comfortable and sometimes have a long-standing relationship with their pediatrician, making the pediatric setting less stigmatizing than a specialty mental health setting. And our partners at Children's National Hospital do annual child mental health screening. So when parents take the child for their well-child visit, they have a few questionnaires that they complete to ask about child emotional and behavioral issues. And so we added to that a screener for parent ADHD. And we thought that pediatricians might be open to this because they already do routine screening at postpartum for maternal depression. So what do these clinics look like that we were working with? Well, they serve primarily Black or African American families, 80%. 85% of the families are insured by Medicaid. And they have an integrated behavioral health program called Whole Bear Care, where there are psychologists that are working alongside the pediatricians and can take referrals, and there can be a warm handoff to those providers. Now, when we started this study, COVID-19 hit, so unfortunately we had to expand beyond recruiting from these clinics to also include screening through the electronic medical record, getting provider referrals, self-referrals, and drawing from the psychology and psychiatry wait lists. This is a map of where these clinics are in Washington, D.C., and many of them are in under-resourced areas. So in the study, we recruited 120 eligible families to either receive parent stimulant medication first before receiving behavioral parent training or behavioral parent training on its own. And we wanted to look at which condition was more effective at improving child and parent impairment, symptoms and functioning, parenting, both observed and reported, overall family functioning and home chaos, and then ultimately the need for child stimulant medication. So this is these are our sample characteristics for parents. They were on average about 38 years old. We had about a quarter fathers in our study, which was exciting because much of the ADHD literature has focused on moms, because moms oftentimes, although this is changing, are the ones who often take their children to various appointments. And as you'll see, because we had to expand our recruitment, we did have somewhat reduced diversity. But the families that we worked with, as you'll see, about a quarter came from the clinics that I was talking about. So we are able to learn more about working with more diverse families, which is really important because the majority of the ADHD literature has focused on white middle-class families. The kids were, on average, age 6. We had about 65% males and 34% females, and again, about the same level of ethnic diversity. Okay, so again, about 25% from those clinics, and then also an extra 15% referrals from those same clinics. And then the families were about half white, and then we see the other races, and about a quarter dads, as I said. Parents were also struggling, besides ADHD, with depression. You can see that over 50% had a past major depressive episode. Many were struggling with anxiety as well. And although not too many met criteria for trauma, most of the families that we worked with that were from the clinics had experienced a lot of trauma, maybe not quite at the level of receiving a PTSD diagnosis. And many of the kids had ODD, as one would expect. So before I mentioned that this was a hybrid effectiveness implementation design, and what that means is that we had assembled a community partner group consisting of parents, pediatricians, office staff, and psychologists who informed us on all aspects of the design, screening, and intervention. And so we assembled this group at the beginning of the study, and as I mentioned, COVID hit, so that changed some things. We had to do these meetings, unfortunately, virtually, but still, we saw that several themes emerged from these families and from this group in general. And these are the themes. And here I have a picture of Dr. Joyce Louie, who spearheaded our qualitative coding. It was amazing to me how much more we learned by having this qualitative component that could inform how we could implement a program like this in the future. So the first was the value of incorporating parent and child mental health care into one integrated treatment approach. And very clearly, the pediatricians and behavioral health providers and our community partner group did truly believe in the spirit of the study. They really did say that their clinical experiences suggested that a lot of times there might be things going on with parents that could really impact, that they see how much it impacts their care of the child. And so they were really on board with our program. The parents and also pediatricians who work with these parents really talked a lot about how for the Black families with whom they work, or for Black families, how there are a lot of families who have experienced negative things in relation to mental health care, and what it means for them to be, for example, the mom of a Black son who gets diagnosed with ADHD, what that means. And this was also at the time of the George Floyd riots and things like that, were really sort of having these parents think about, well, if my child has ADHD, what is this going to mean? What kind of, what could happen if my child, has a conflict out in public? What is that going to mean? What does it mean to have, on my child's school records that they have ADHD? And so a lot of hesitancy around that. And it was, I think, really important conversations that were had. The next theme was sensitivity required when speaking with parents about their own ADHD or mental health. So although we've been doing this research for over 20 years now, asking parents about their own mental health, what we found is that when we were working with parents in these clinics, a lot of times it wasn't well received. There were, questions around, well, why am I being asked about my mental health? I'm here for my child. I'm here, to get treatment for my child. What does it have to do with me? Or are you suggesting that there's something wrong with me and that's why my child is struggling? When that wasn't our intention at all. What we were hoping to do is to help parents feel supported. But just getting that 6-item ADHD screener didn't seem to work that well. Also, attention to medication hesitation is really needed. So many parents, even though our study didn't involve giving the child medication, a lot of parents had concerns about ADHD in general. As soon as they hear ADHD, the next thing they think is, well, are you suggesting that I medicate my child? We found that a lot of parents, once they found that there was a medication component to this study, really didn't want to enroll. And so this is an important lesson for us for the future, that taking an approach that doesn't involve medication could be more inclusive of families. Also, the pediatricians with whom we worked on our community advisory board had different suggestions for the way they've talked with families about medication in ways that were more that they were more open to. Parents and pediatricians had a lot of suggestions for effective versus not effective strategies to talk with parents about their own ADHD. So parents really did feel that it would be much more helpful to have a conversation with a trusted provider. So someone that they already knew and trusted, that they could talk to them about, have you ever thought that you might have ADHD? A lot of times, actually, when we're talking, and I think many of you clinicians have encountered this, that when you talk or when you're doing an assessment for ADHD, a parent might say, well, gee, that sounds just like me when I was a kid. Or that sounds a lot like the other parent or my spouse or my partner. So that is sort of a natural way to open the conversation. So parents said that they would overwhelmingly prefer to have that type of conversation versus getting a questionnaire in the waiting room. But the problem with that approach is that pediatricians might see lots and lots of kids in a given day, and so they might not have enough time to have those difficult conversations. So through this study, we even created infographics for them about different ways that they can bring this up if they suspected ADHD in the parent, different ways to approach that. Okay. So anyway, I think that this experience of this study, we saw 120 families, and I feel like what we got from these community partner groups was actually some of the most valuable information. And I think that going forward, I will definitely be incorporating qualitative methods in my work, because I feel like we got such a richer sense of what we could actually do to implement some of these strategies in the real world. Next, I want to tell you a little bit more about our integrated behavioral parenting program. And again, this sort of grew out of my dissertation. For my dissertation, we followed the summer treatment program with this cognitive behavioral program, the Lewinson Coping with Depression course. But really, our sort of conceptualization around parent mental health is more in line with this oxygen mask analogy, right? So let's help parents to be at their best so that they could put their all into parenting their child. And my dissertation was actually a bit backwards, right? So they had gone through the STP, and then we treated them for their depression. And so what we've done since is sort of integrate the treatment of parents' mental health with a behavioral parent training program. And the reason that we've done it like this is that of the 120 parents that were in our study and all the parents we've treated with various iterations of this program for years and years, many of these parents would have never gone and gotten treatment for themselves. They'll do anything for their kids, right? But will they actually take the time to help themselves? And many of them might have struggles with depression or struggles with anxiety or struggles with ADHD symptoms that might not quite reach the threshold of diagnosis. And again, these parents don't have a lot of time, and the time they have, they'll often devote to their kids instead of themselves, right? Sound familiar for all the parents in the room. So what we did was we really sort of folded a lot of these skills for parents into a parent training program. And the prior work that we've done has shown that this approach is superior to a standard parent training program. Okay, so again, this oxygen mask analogy, for those of you who've flown recently, maybe you've flown here, they always say if you're traveling with a young child, put your oxygen mask on first so that you can actually help your child, right? And it's the same idea for parents. Another common saying that you might hear is you can't pour from an empty cup, so you have to fill your cup first. So this is a table that describes sort of the standard parent training skills that we use, when we try to treat ADHD or oppositional behavior in kids, and then how the cognitive behavioral skills and organizational skills that are evidence-based for depression, anxiety, ADHD can be folded in. So I'll give you a couple of examples. So we all know that structure and routines are good for kids, and especially for kids with ADHD. But many of the families that we've worked with where the parent has ADHD, there really is no routine, right? The wake time, bedtime, meal times, homework time, it's not as structured. And oftentimes the parents will tell us, I like to be spontaneous, or, I'm not really a very structured person. So we work with them on time management strategies to help them to be able to, to be more structured with their child. Similarly, we work with parents on praising their kids. But if you're sort of in a negative mindset, it could be much harder. And so we work with them on increasing positive thoughts, decreasing negative thoughts, identifying things like negative filters or other patterns of unhelpful thinking that could interfere with them seeing things that they could praise in their child. We also talk with parents about being advocates for their kids at school, but many of the parents might be a little bit on the aggressive side or on the passive side, so we work with them on different social skills and assertiveness strategies that they could use when advocating for their child. Similarly, we teach them to ignore minor misbehaviors in their child, but really might not teach them how to manage some of those emotion regulation aspects of ADHD that could interfere with that. So if you're attending my workshop later this afternoon, you'll learn all about this intervention. But this is the program that we used in this TPAC study. We also, going back to the end user, the parents, we asked them which skills they liked the most. And this is from a subsample. This was a summer student that I had last year that showed that parents tended to prefer the overview or the understanding the cognitive behavioral therapy model. Pleasant activities, time management, and assertiveness training were the skills that they liked the best, focused on their own mental health. And then with regard to parenting skills, they most liked special time, structure and routines, and then praise and rewards. Okay. Another important aspect of this study that was really unique when we wrote the grant, but of course was telehealth, using telehealth, because we know that parents of young kids are stretched really thin. And so we wanted to, figure out a way to make it more accessible for them to be able to receive the parenting program. And I know some of the pioneers in doing parenting intervention via telehealth are here. And so this was a really unique part of the project, but then of course the pandemic hit after we ran 2 families through the protocol. So all of a sudden it didn't become unique anymore. But what we did was we had these embedded psychologists in pediatric primary care in under-resourced areas of DC. We trained them using 2 half-day workshops, and then we would meet with them weekly for a half an hour to an hour, whatever they could spare, to ensure manual adherence and to provide supervision. And in the spirit of the hybrid effectiveness implementation design, they billed as usual for services to make this a more sustainable model. The treatment completion rates were pretty high. Parents attended over 8 to 9 of the 10 sessions. We were as flexible as possible with scheduling and rescheduling. We provided reminder emails, calls, and texts. And one of the nice things about telehealth is that if someone didn't show up, the providers could give them a quick call, and oftentimes they could hop on, which wouldn't be possible if they had to travel into Children's National. And it seems from our preliminary analyses so far that parents who received medication first reported more skills practice at home, and that their therapists felt that they were reporting more adherence to the skills at home. So that's huge, but it's preliminary. We're still cleaning our data and making sure that in fact is going to stick. But that would be a really important finding if it holds. As I mentioned, there were lots of benefits. So first of all, parents who didn't log on, which was very common, they could be called, and then we could ask them to log on. A second caregiver, if there were 2 caregivers in the family, they could log in even if they weren't in the same place, right? So we had a lot of co-parents who were able to join the sessions. There was more flexibility with scheduling and rescheduling, so many of the parents were sitting in the parking lot at work in their car when they logged on to the sessions, which accommodates working parents and encourages more consistent engagement. Of course, telehealth also reduces travel time, expenses, and just the stress associated with commuting the sessions, which was especially important during the pandemic when many of the parents who didn't have cars would have had to take the metro, and there were lots of concerns about contracting COVID on the metro. This really expanded our reach, especially with SciPact. So many of our providers were able to provide services across state lines. And also we got a window into their home environment. And we could coach them in the moment with their child, which was exciting. And then they didn't have to arrange for childcare. So the providers were very, very positive about using telehealth. You can see this quote. And then the parents. Many of the parents said we couldn't have done this without telehealth. It allowed for us to have both parents participate. My life is already so hectic. I don't know how I could have fit in another thing. But there were lots of challenges of telehealth, and particularly with our lower resource families. Many of them didn't have access to adequate devices, so almost everyone has phones, right? Cell phones, smartphones, but when you try to show them slides on a smartphone, it doesn't work as well as if you have a computer, a big computer screen in front of you. Some parents were more or less familiar, comfortable with using technology. And then the telehealth platform, we had many transitions during this study, like any implementation study. Children's National changed their platform that they were using for telehealth, and so this was another thing we had to deal with. Also, privacy concerns. So many of the lower resource families that we work with didn't have private spaces to meet in their home. And we were talking about some sensitive things related to their own mental health that they didn't want their kids to hear. So that was an issue. And then, of course, we'd have the parents logging in from public places where it was clear that they didn't have privacy. Sometimes they'd be driving and log in, and we'd say, "Are you driving?" No, I'm not. But clearly they were, so we knew that wasn't safe. And so there were many things like that. And then, of course, home distractions or constant interruptions, which were sometimes opportunities to coach them, but other times it was just really hard to get them to sort of sit down and focus rather than doing the dishes or folding the laundry or other things. And it wasn't clear how engaged they were. Okay. So this is another provider testimonial. And so throughout this talk, you can see that we really, really tried to engage the people that we were working with, the end users, so that we could make sure that what we were trying to do would be sustainable. Some additional considerations is that our sessions did have a lot of content. And so the book that we wrote that this intervention is based on encourages real-world providers to take as many sessions as they need to get through each module, but because this was a research study, we had limited it to 10 sessions. And so especially when working with parents with less education or less familiarity with psychological concepts, it probably was too much information. And then our embedded providers oftentimes have more of a consultation model where they might meet with a family 1 or 2 times. They might meet with them for 20 minutes or 30 minutes. And so more of a bite-sized approach might be needed in primary care, which I believe is also related to some work that's been done here at FIU. Okay, so to sum up the implementation of behavioral parent training, delivering the integrated parenting interventions for caregivers with ADHD is feasible for real-world psychologists integrated in primary care. We probably need to expand well beyond psychologists to social workers, nurse practitioners, family navigators, master's level therapists. That would really expand the reach of the work that we're doing. And the telehealth afforded many benefits when delivering this intervention, but there were also some challenges. And so what we're trying to work on now, particularly Nicole Lorenzo, which is a graduate of the FIU program, is to reduce the session content and length to make it more feasible in pediatric primary care. So what are some lessons that we learned from this? Well, there are lots of complexities when screening for parent ADHD in pediatrics. And we would have never really understood this if we hadn't actually been working with our community partners very closely. So as I mentioned, parents don't prefer questionnaires around their mental health. They would much rather have conversations with trusted providers. There are some structural barriers around this, but the benefit of having embedded providers is that the pediatrician who the parents already trust can do a warm handoff to mental health providers who could continue the conversation. So we still need to do some quality improvements and more work on our implementation toolkit to make sure that this is sustainable. And we've often thought about whether family medicine or adult primary care settings might be a more natural place to ask about parent mental health. And we've also thought a lot about family navigators and how they could help, especially our most stressed families, kind of navigate care for the child's ADHD. In particular, with our families from the clinics, many have had unique experiences with the healthcare system, and we really must practice cultural sensitivity around talking about parent mental health and discuss the beliefs and knowledge around ADHD and medications, engage in shared decision-making with families to the extent possible, and it's incredibly important to diversify our workforce so that families feel as comfortable as possible. We had many other study challenges. I already mentioned, of course, COVID. We had IRB delays because we were working across 3 institutions. We had the national stimulant shortage, which we're studying now in my lab. Children's national transition to a new electronic medical record system. And all of these transition created stress for the office staff in these pediatric offices who were handing out our questionnaires. The families were stressed because they had to re-register in the system, and with the literacy concerns, that made it even harder. There was turnover with our pediatric champions and our psychologists embedded in the clinics. And we had to expand our recruitment strategy, right, reducing the diversity of our sample. But still, we feel like we've learned a lot from this study. So what's coming next? Well, we have begun to think about working with expectant individuals during the prenatal period and infancy. So individuals who are pregnant, who have ADHD. We know that their babies are going to be at risk for ADHD, so we are, again, working with community partners to come up with an intervention, thinking about when someone is pregnant, they have all these doctor's appointments, they're supposed to eat well, exercise, sleep, take their prenatal vitamins, they have mommy brain. Once the baby is born, they have to deal with the baby sleep schedule, not getting enough sleep, the feeding, preparing the home, the nursery, the hospital bag, and avoiding alcohol, certain foods, and stress. So that's a lot, right? And all of this taxes one's executive functioning. So we have this MAMA study, and this is in collaboration with Heather Joseph at Pitt and Nicole Lorenzo at American. And we're working on community partner groups informing an intervention, which we're just about to pilot now, and hoping to be able to do a larger scale study. To sort of summarize some of the research that I talked about today, parent ADHD is associated with child developmental and treatment outcomes and should be assessed and treated. It's very, very common, as I pointed out, when a child has ADHD that at least one parent is struggling with ADHD as well. And if so, unaddressed, it can really throw a wrench in your ability to support the child and family, so we can't ignore it. And simply medicating the parents doesn't seem to be enough. We really need to take both a behavioral and pharmacological approach, or for some families, maybe they're not open to pharmacological, so we need to really focus on teaching them skills that could be helpful with their child. And recently we've been focusing on implementing these treatments in real-world settings, schools, pediatrics, with diverse youth and families who may be less likely to get treatment. We've seen Melissa Danielson's research showing that diverse families are much less likely to get treatment for ADHD, including school accommodations and school-based services. And so we really need to do careful mixed methods work to be able to be effective in these settings. I was happy to see that the former Surgeon General put out this advisory on how caregivers need care too. So if you haven't read this advisory, you could search for it. It's called Parents Under Pressure, showing that how important it is that we are focusing on the well-being of parents, which was really exciting to see given the focus of our research. And so hopefully these efforts will continue. I always love this saying, when little people are overwhelmed by big emotions, which we know many kids with ADHD struggle with this, it's our job to share our calm, not join their chaos, right? And so, but it's so hard. It's easy to say and hard for these parents to do. I know we're running out of time, so I've just talked about a couple of the studies and the areas of research that we do in our lab today. But this is, if you think about sort of a lifespan perspective, starting with the MAMA study, the pregnant moms, all the way through to our work with parents and with college students who are experiencing major transitions that tax their executive functioning, and work in the high schools. This was just one piece of what we're doing. We also have these videos, 2-minute animated videos if you're interested, depicting evidence-based strategies for ADHD. And I want to acknowledge all my collaborators and my lab. So thank you.
Well, first of all, I appreciate the fact that you talked about diversity in the workforce in terms of engagement with those parents, especially the African-American moms that can be a little bit closed off to therapy. And I used to work in D.C., and it's called the Chocolate City for a reason. And one problem that I always had when working with African-American parents is a lot of them culturally are kind of old school when it comes to parenting. And you talk to them about kind of time out and things like that, and they can shut you out real quick.
Right.
So they're like, I have an intervention for you. Here's an intervention.
Yes.
So, and I've always been seen as kind of like soft when addressing some of these things. I was just wondering how you address the kind of old school parents.
Yeah, that's a great question. And I have a slide in my workshop this afternoon addressing that. I think that's such an important point. And so really throughout the treatment, what we do is we have these conversations around, how would people in your family react if you parented in this way? Or what do you think your friends and family will say? How is this similar or different to the way you were parented? And we use a lot of motivational interviewing as well, motivational strategies. And so we don't want to close off parents, right? We don't want them to feel that we don't understand. So we try to roll with it, and we try to encourage them to give this a try. Some parents, when it comes to timeout, that's a tricky one. Some parents just don't want to do timeout, but they're okay with removing a privilege or taking something away. And so we kind of, try to engage them and get them to give things a try, to consider it an experiment, and to go with it. So we're lucky that our team at Children's, for the most part, has been working with families in these settings for a long time. And we're lucky to have a pretty diverse group of pediatricians who are on the same page with us. So I think, and oftentimes through our community partner groups, the pediatricians have talked with us about this is what's helped us with families in the past. So we really try to honor their expertise and not go in and act like we're the ones that hold all the knowledge. That we really want to learn from them too about what's worked with them around timeout, medication, all different topics. So I think that's really important. But we can't deliver our evidence-based treatments without attention to those things, or we're really not going to get anywhere. Thank
You mentioned emotional regulation as like an important feature when discussing the research with parent with ADHD and the child with ADHD. Mm-hmm. Could you tell me more about that, like in terms of how like the symptoms of ADHD from the parents, how it affected with the interactions with the child?
Yes, yeah, that's a really important question. So, you know, they always say if you meet one person with ADHD, you've met one person with ADHD, and that goes for parents as well. So some struggle with regulating their emotions. And so if you have a child who, by definition, is doing things that could be sort of frustrating, or if you're pretty impatient and your child is taking a really long time to get things done, that it could be really hard for the parents to sort of stay calm and to use the types of skills that we all teach them are most effective with kids with ADHD. So it's going to be hard for them to do their, ignoring or differential attention if the child is doing something that gets on their nerves. And maybe it's even something small, like, dancing around or talking too loud or tapping their foot or whatever. And so we try to understand from parents what their triggers are. And oftentimes the parents will overreact, right, and yell or spank or do something that then they don't feel good about. And that, in our CBT model of thoughts, feelings, and behaviors, that sort of reinforces their idea that I'm a terrible parent, this is my fault, I'm not up for this, or, I can't do this, feeling depressed, hopeless, bad about themselves as parents, and then that just sort of fuels the depression more. So what we try to do is to normalize those kinds of reactions, right? Anybody here who has kids, raise your hand if you never yell at your kids. I can't raise my hand. So it is sort of normalizing, and that's why in some of our earlier studies, not this one, where we've done groups, it's been really powerful for parents to say, other parents that are in the group will say, I lost it the other day, and I'm just a horrible person, or I'm a horrible parent. That they can sort of challenge each other in that way. So I think that this happens a lot in general in parenting programs, but I think it's more likely to happen when parents are struggling with ADHD themselves.